Headphones in. All right, so the title of the talk is called The Art and Science of Patient Experience. And just to kind of give you guys a little bit about me, I did my undergrad at Fresno State, where I studied with Dr. Marianne Jackson and Chris Wilhite. They were primary mentors for me, where I spent some time in the Autism Center, and I realized that was not the career for me. And so I was introduced to OBM at that point, and I went and studied actually with Dr. Homenfar at UNR, which specialized in an area that I was particularly passionate about, which is leadership and motivation in organizations. And through that experience, I also had the opportunity to be exposed to our School of Medicine program. And that was very beneficial to me because I was able to get exposed into healthcare. And part of my dissertation focused on really my work that I was doing with the School of Medicine, which included looking at and developing a communication training program for interdisciplinary providers, which focused specifically on medical and nursing students, and ways to really use behavior analytic work to dig down into the cause of communication errors within healthcare. So through that interaction, I was able to be exposed to Renown Health, which is where I am today. We are located in Reno, Nevada. Renown Health is the only locally governed not-for-profit healthcare network, and also the largest employer in Northern Nevada. We employ roughly about 6,700 employees, and our facilities account for about 946 beds for patients. We are partners with Stanford Healthcare, Stanford Children's Health, and also Stanford University School of Medicine. And one of the things that I really appreciate about this partnership driven organization is we are heavily affiliated with the UNR School of Medicine. So for today, what I thought I would kind of speak to you guys about are these components of patient experience. And when you think of patient experience, you probably think more along the lines of the clinical excellence and operational excellence. So when I'm talking about clinical excellence, did you cut into the right body part on my body? And operational excellence may deal more with things like appointment time and delays of that experience. But where I've more recently been able to focus my work is in the area of service excellence. So in addition to my role as the Director of Special Projects, I've also stepped into the role as the Interim Director of Service Excellence here at Renown. So what I'm going to cover today is kind of giving you guys some history and background in terms of what clinical excellence is versus service excellence, and really giving some high-level overview of these areas to try to inform you what an amazing need there is within healthcare. And so if I were to summarize the purpose of this talk, it's to really open the door and provide some context to people who are interested in OBM so that you might find some areas of interest where we can wrap you into the healthcare world. So I'm going to just pause for a second. Are there any questions? Oh, sorry, what was that?
Right now we're not showing any questions in the chat.
Okay, Amber, if you don't mind just kind of prompting me verbally so I can switch back over, because I can only see my slides.
Okay, yeah, I can do that.
Okay, thanks. All right, so patient experience, what I consider to be part one, is deals more with the science. And so when you think of the science of patient experience, what comes to my mind is quality and clinical excellence. So quality is obviously very important within healthcare because we're dealing with lives, we're dealing with keeping humans alive. And there has historically been a lot of data and a lot of research to support improvement in clinical quality because we're held accountable to things like mortality rates, sentinel events, and wanting to keep the patients and families that we serve in their most healthiest state. So a lot of times with clinical excellence, they have a very strongly developed method where they're defining and discovering what's happening to the human body. They're discussing and deciding, so they're really evaluating with interdisciplinary teams on the best approach to improve clinical quality, and then also delivering and driving those methods. So it's a very plan, do, study, act methodology that they really embrace and continue to evaluate the methods that they're currently choosing. So with clinical excellence, we have patient safety and quality. With operational excellence, we tend to focus on things like efficiency and effectiveness. So the difference between efficiency and effectiveness for me is you can only be as efficient of a process, or you can only have an efficient process as it is effective, meaning, are you using the right people? Are you using the right tools to get the job done? That's more of that effective conversation. Whereas efficiency is focusing more on lean methodology, where we're reducing redundancies and waste and improving and streamlining processes. In service excellence, we tend to deal with more of the human side of the way the service is being delivered. So are our patients and families satisfied? Are we designing an environment that promotes the experience that we're wanting them to have? So for today, I'm just going to kind of break apart clinical excellence and service excellence by first starting with a history of what is called the patient safety movement. So this is just really to give you a context for those of you that are interested in healthcare. A lot of these reports that I'm going to be mentioning today are landmark foundational reports that really pave the way to study behavior-based safety really within healthcare. So the first piece was in 1995, or one of the first pieces, I guess, for this timeline, we'll call it the first piece, was called the Emergency Department Study, or ED study, and it was a multi-year Department of Defense research project that was initiated. And really what sort of set the stage for this research was there was a lot of research happening in aviation to better understand why planes were crashing. And what they ended up finding is about 60 to 80% of those were due to human error rooted in communication failure. So people not working together in teams due to psychological factors related to hierarchy and whatnot. So that's when the Med Teams project really began. And the Med Teams project built upon the ED study, where they reviewed emergency department management cases, and they found the same sort of statistics that were happening in aviation were also happening in healthcare. So if that's the case, that led researchers to really want to explore what are the methods that are effective within aviation that we can then transfer into healthcare. So in the late 90s, early 2000s, one of the most landmark seminal piece reports by the Institute of Medicine came out in 1999, which released the statistic that upwards of 98,000 American fatalities happen every single year due to human error. And so the Institute of Medicine, that's what that snake stands for there, that's their symbol, helped to inform a lot of the government work that was happening around developing patient safety programs. And in 2003, the Joint Commission released their national patient safety goals. And 3 of those 7 were actually related to team communication. So again, human error. How can we, if we were to look at humans as trying to provide a structure to really standardize their behavior, to standardize their communication interaction, we would be able to reduce a lot of these fatalities that are happening every single year. So the AHRQ started to implement some of these training strategies that were happening in aviation, and developed what is called crew resource management, and bringing that type of technology into the team training arena within healthcare. As of 2004, there was a 100,000 Lives campaign that was launched, which really was to try to bring awareness around how many lives can we save if we start having a better commitment to patient care. And this goal was met in June of 2006. And in 2005, we had the Patient Safety and Quality Improvement Act that was signed by the Department of Human and Health Services. And we had what was the first Teamstepps pilot curriculum. And for those of you that are interested in team training, whether that be in healthcare, whether that be in high fidelity industries, I know one of the people listening in on this talk is a previous colleague of mine who is doing some work in the energy industry, dealing with oil rigs and gasoline. And these same principles, which are leadership, communication, situation monitoring, and mutual support, really apply to any industry that involves teamwork and care coordination. And so Teamstepps, given its empirical validation and consistent repeated improvements in healthcare errors, they released the Teamstepps training to the public domain for any organization to adopt for free. Now, if you look on the AHRQ website, their national implementation, they provide an extensive amount of resources for anyone who would like to download and print and use the curriculum, also to look at empirically validated studies. And how their training works is they have regional training centers, which I have listed on here, and this image may be a little out of date, so they may have more at this point. But you can go to these regional training centers. Now, this part does cost some money for you to go and have a 2-day training, but you can become a master trainer so that you can then take that information back and implement in your own organization. And in 2008, CUSP was introduced. And I'm looking at my notes here just to refresh on what CUSP stands for those of you that are interested. Let's see here. CUSP was the Comprehensive Unit-Based Safety Program, and it was introduced to reduce central line-associated blood infections. And so as you can see, these different sort of initiatives are coming up around how do we begin tackling these initiatives one-on-one. Next, the Center for Medicare and Medicaid Services was initiated a partnership for patients to reduce hospital-acquired infections. And as of more recently, what is happening in the healthcare industry, and I guess you can say the provider education industry, is that different accrediting bodies that go through and accredit medical education, nursing education, and all these different programs are now requiring that we have an interdisciplinary approach to the way that we train our providers, because there was this issue where all of these healthcare providers were trained in isolation, and then they're thrown into the healthcare setting, and they're expected to know how to work together. They're expected to know what roles each other fills within the care team. And as we know, as behavior analysts, that whole piece of behavior is its own repertoire that really has to be trained, shaped, given feedback in order for people to conduct that behavior effectively. So where are we at today with all of this stuff, and kind of really why am I giving you all of this context? Well, to be honest, because it's concerning that medical errors, even having that history, are the third leading cause of death in the United States. So we have heart disease, we have cancer, and then we have medical errors following closely after that. That means more people die of medical errors than car accidents every single year. More people die of medical errors than other sort of chronic diseases that are being developed. And if this is something that we as humans can control through behavioral modification and being able to design environments to really prevent these types of adverse events, this is the biggest calling that I've ever seen for behavior analysts within the field. So to give you kind of an example of which are the most common root causes that are relevant to medical errors and where as behavior analysts we might be able to focus our research on are 1, medication errors, 2, hospital acquired infections, 3, teamwork and safety culture, falls, handoff errors, diagnostic errors, and surgical errors. And so I'm sure most of you guys are already having a lot of thoughts coming up in your head thinking, oh, what about a task analysis? What about checklists? Like, how are we ensuring protocol adherence? Well, these are all the types of conversations that I really want to drive, and I'm going to save that for the end. So if you can kind of keep any thoughts in mind, unless you have any like really fire burning questions, I want to have this discussion about clinical excellence and service excellence and how we can use OBM to integrate both at the end. So some proactive strategies that we might take or are currently taking within healthcare in the environment to address these types of errors are one, how do we design an environment that really promotes the outcome that we're looking for? So one, there are standards of clinical care, also known as best practices, that we are held accountable through accreditation processes. Training, so how do we communicate those best practices to our providers? How do we continue to update our providers on these best practices? And lastly, we also have protocols relevant to patient rounding. So there is a care team, potentially nurse managers or the staff nurses that are on that particular shift or unit. They are going around and double checking from a quality perspective wound care. They are making sure that adherence to medication is all on track. And then we also have what we are proud that we use at Renown, which is lead rounding. So we actually have our senior management team leaders on the floor, rounding with employees, rounding with department leaders. So if there's anything from a quality perspective, we can identify proactively and get something taken care of very quickly. So one example might be there's an environmental barrier that could potentially risk someone falling within a particular unit. And so a lead rounder can actually help to advance that process so we can ensure that quality standards are being met 100% of the time. The reactive strategies involve things like clinical audits. So when there is some sort of patient safety event that happened, maybe some sort of sentinel event that happened, every single one of those events is reviewed. We have, in addition to those group reviews where we have experts, interdisciplinary experts really evaluating where, if any, errors were made and how to correct that in the future. In addition to that, we also have an ongoing chart review. So while the patients are in our care, we have a team they're called the clinical documentation team, and they're continuing to really update and review and ensure that the charting process has been done accurately. And if there were any errors made during the stay, we can still correct that. Another really important, and as a behavior analyst, I feel very, very passionate about this particular piece, is data transparency. So data is not beneficial if it's left in an Excel file on somebody's computer. Data is beneficial when it's transparent to our employees and to our leaders, because we be able to use that information to inform decision-making, to prioritize interventions moving forward, and to ensure that our interventions that are being implemented are effective. And lastly, we also use leader coaching sessions where we can actually take time to provide that feedback and help them to prioritize their interventions and trainings based on what data we have for their unit. But also, as a behavior analyst, I would also say it's incredibly important to use this opportunity to provide recognition, because we want to ensure that the positive practices that are happening in the workplace are being recognized and maintained. So I'm going to pause there for a second before I get into the service excellence piece, and I'm going to skip over here and see if I have any questions from you guys on the clinical quality side.
If you guys have any questions, you can enter them into the chat that's to the right of the webinar screen.
And no pressure, no need. If nothing comes up. Okay, great. I'll go ahead and keep going. So the art piece, now in graduate school, I had the opportunity, like what really brought me into healthcare was the study of medical errors and how to reduce medical errors and how to focus on team training and orientation. But more recently, where my research and my work is currently being directed is more towards this art piece, because the art of the way we deliver the care is something that is understudied and but highly valued in healthcare. And actually this is I mean, I'm really sharing a gold mine of information in terms of potential career interests and ways to kind of grow and expand within OBM, because there's not, even though it's healthcare is the world's largest service industry, the quality of the service is infrequently discussed in the medical literature. And I think a huge piece of this is that people do not know how to really take service behavior and define it objectively and measure it objectively like a behavior analyst can. So when you read about service excellence or patient experience in healthcare, you typically tend to have more conversation around cultural interventions. So you see things like, what are we doing with leadership? What are we doing with communication? How are we training these people and continuing to develop these people? And what processes are in place to continue to maintain that behavior? Because it deals more with employee engagement and engaging your employees so that they're prepared to deliver the service you want customer that they interact with. So again, it deals more with building a culture. The companies that are most successful should be incredibly familiar to you guys up on the screen. We have Disney, we have Nordstrom, we have Google, Starbucks, Ritz-Carlton, Apple. And what happens with each one of these brands is that every time I walk into Disneyland, I'm exposed to the same exact standard of care every single time. The music is playing, the streets are clean, they've got cinnamon blowing in the air, just kind of make me even happier. And what it does is it creates a culture that I walk into and I just escape from another land. You know, an adult, not so kid-friendly version of this would be kind of like a Burning Man experience, where for those of you that aren't aware of Burning Man, if as a resident of Reno, Nevada, you're kind of obligated to at least attend one time. But what makes the continued and repeat and the loyalty of attendance that continue to go back is the culture really that is created. And when you walk into that environment, you step into that culture from day one. So what's happening is organizations like the Ritz-Carlton, like Disney, they're realizing they have something that other people don't, and they've started to really share their secrets by developing workshops, books on how they train and develop their leaders, on how they manage people, on how they have quality service, brand loyalty, etc. And really the fascinating thing about, and I've just put 2 books up here that I've gone through, the New Gold Standard from the Ritz-Carlton was particularly a valuable read to me, because really it's very much based in behavioral science. And having gone through a Ritz-Carlton training myself and interacted with some of the leaders there, they will tell you that they've had psychologists go and design the interventions that they use and the way that they develop their culture that has created that brand loyalty, not just with their customers, but with their employees. They have a very, very low turnover rate because the people are committed to the brand and they use the phrasing, I am the Ritz-Carlton. It's not I am an employee of the Ritz-Carlton, but I am the Ritz-Carlton because I am a part of it. And so it brings more of an ownership. And I think the consistent messaging here that's important is that each of these companies, and it's really shocking to hear in healthcare, but the employee is first. So at Ritz-Carlton, they put the employee first and they empower the employee and take care of their employees so that the employees feel valued and they feel like they are an important member of the care team who is then sharing that feeling of importance and enthusiasm with the customers that they interact with. So, sorry, just had to take a quick drink there. I wanted to also go over you guys. So this last portion, I just have a couple different books that I wanted to share here, just in case any of you are interested in checking out. But this, the book that I have presented here is by Paul Spiegelman and Brett Barrett. And they break down 9 different principles here on how to put your employees first, how to empower them so that they can then take care of your patients. So a lot of this stuff and why it's important to bring up is because there's a lot of connection to the stuff that we do in behavioral science, particularly in behavioral systems analysis, when you talk about building and designing a culture that embodies and really occasions the behavior that you're looking for. Having a defined mission, vision, and values, injecting fun into the employee culture, really reinforcing the behavior you want to see. Prioritizing employees' well-beings and the totality of their lives, so ensuring that sort of work-life balance. Connecting employees to the community. Don't tolerate employees who don't fit the culture. So how do we continue to reshape, and rework the environment so that it's promoting the behavior we want, but really from a realistic and transparent perspective, knowing when this particular employee has a strong enough history that we're not going to be able to see the results we need in that quick of amount of time or in the desired amount of time. Allowing ongoing dialogue between leadership and staff. So talking about that transparency. This is just, it's a great textbook, or it's a great book that I would really suggest you guys reading. So with the proactive strategies to designing an environment that promotes the service quality that you would like, one, in the environment perspective, having a location that is easy to navigate. So in healthcare, you often have times where you are in a rush to get somewhere. If you have a family member in the emergency room, if you have someone whose vitals are dropping in the ICU, you need to be able to navigate and get there quickly. So wayfinding has a lot to do with antecedents and how we guide and direct people, having standards of arrival and care. And what you guys will notice is a lot of these principles are the same for both the clinical excellence in addition to the service excellence piece. They're just refined just a little bit. And so for training, we want to focus on service behaviors. What are we expecting every single interaction to look like? In addition, looking at provider communication. So how do we shape the repertoire? Because as we know, when you have physicians who are trained in isolation, and there is a great history about physicians being trained to be incredibly autonomous, where they work alone, they come to make decisions alone, and they are the ultimate authority. What they lack sometimes is the ability to translate that clinical information into a way that as a patient, I feel comfortable and receptive to that information, and I'm able to validate understanding. So we have to really design programs that are aimed to improve those particular service initiatives. Rounding, it's the same strategy, it just looks a little bit different. So instead of me wanting to round, which for those of you that aren't familiar with the term rounding, it's just having members of the care team going around and interacting with patients on the unit. The rounding strategies that are important are having our care team interact with patients in terms of their human needs. So not just how is your pain, let me check your wound, but also how is the volume? You know, have people came by and interacted with you, and is there anything that we can do to improve your experience? And the key part here is reassuring them that you have time to help with whatever they're asking for. And when it comes to the lead rounds, they're looking for the same type of service needs in addition to the clinical quality needs. They're able to address and help improve as quickly as possible. One of the pieces that's important about rounding, though, is having a mechanism to track and display real-time feedback so that your providers on that unit are able to actually look and say, wow, in the past 30 minutes, we've had really low scores with noise when we've had people going around and rounding for the care team. And so maybe one of the things that we can work on as a team is driving down noise to improve overall patient experience. For data analysis, we have on the reactive side, two of the main types of complaints and grievances, or two of the main types of data that my team focuses on are complaints and grievances. Complaints are verbal concerns that are expressed to members of the care team, and grievances are in some sort of written form, whether it's a Facebook post, whether it's a letter that was mailed into our CEO, whether it was a letter that was dropped off with one of the care team members. It's some sort of concern or issue that is being expressed. And then we also have patient survey data that is led by, we actually work with Press Ganey, who creates an integrated Press Ganey and HCAHPS acute survey for us that asks questions around your overall rating, how was your communication with your provider, and very macro and micro level details about the patient experience. But as I mentioned with the clinical quality piece or clinical excellence piece, the data is only valuable if it's actionable. So as employees, we have to share the data with our employees and our staff, and having it more immediate and more frequent, the better. Also, this data, the complaints and grievances data, the patient satisfaction data, this is something that is included in leadership reports so that they're able to discuss at the senior management team level. And lastly, when we're doing leader coaching, it's not just important to prioritize clinical excellence interventions, but also finding ways to recognize and use data to intervene on how to prioritize our most important and most frequently mentioned complaints and grievances. Any questions before I get into the OBM part? All right, I think we're good. So here's some strategies that I have learned out. When we think about where can we bring OBM, I mean, my first response is just everywhere. But if I have to sort of summarize and be more specific, I've outlined 4 different areas. So first and foremost, behavioral systems analysis is incredible when you're understanding wicked complex systems like healthcare. The advantage it gives you is being able to understand that by altering one process in one particular unit. So for example, if something happens in telemetry, or if something happens in the emergency department, how does that impact other units on within the inpatient setting? And I am constantly surprised at how beneficial, one, this training is, but 2, how often you interact and experience people who weren't trained to think in that very systemic perspective. Because we're not just focusing on behavioral systems, but we're also focusing on the behavioral contingencies of the individuals who operate within those systems. And 2 of the just areas that I would suggest really being familiar with to understand behavioral systems analysis is, one, Ramona's work and Ramona Homenfar's work in the 5-turn meta contingency, and understanding how all of these different pieces operate within the context of a greater cultural milieu. And also Maria Malabuk's Paradox of Organizational Change was absolutely fantastic. And Maria's book was something that I've actually shared with other senior leaders at Renown Health. And it's written in a way where you don't have to be a PhD in behavior analysis to understand the concepts. It teaches you about interlocking contingencies. It teaches you about the critical importance of mission, vision, and value, so you can continue to ensure your behavior is aligned through process mapping, you can not only look at a current state, but an ideal future state, and it provides you direction on how to get there effectively. Obviously, behavior-based safety has a lot of influence and a lot of similarities and generalization into the work that is happening in healthcare. The two books that I have here, one of them is from a behavior analyst within the field, Scott Geller, but the other one, the Checklist Manifesto, is more of a just general, if you're looking for something to read, but it really applies behavior analysis and behavior analytic principles in structuring behaviors and creating an interlocking contingency of multiple behaviors into a book that is easy to digest, easy to read. And the value that I think is really important of reading these sort of offline books is that it helps you to communicate with the leaders that you interact with on a day-to-day basis. Because if I were to jump into a meeting and I were to start speaking about antecedents, behavior and consequences, and motivating operations and motivative augmentals, people might start to look at me cross-eyed. But if I'm able to express to them how a sign on a wall turns into wallpaper after a period of time versus using antecedents and habituation, people tend to be more receptive and they understand that content. So when we talk about designing behavioral-based systems to improve safety in healthcare, and we're looking at checklists and task analyses and audits and observations, and how do we go through and tie behavior to each of these steps? So again, we're taking the person out. We're looking at and measuring behavior and processes. Also, behavioral principles, just having the basic understanding of behavioral principles and how to understand and really evaluate something that is objective versus subjective. Because a lot of times what I'm learning is that in healthcare, we may be measuring the wrong things. So when we're trying to look at a process that is happening in the emergency department or on a particular inpatient unit, we want to ensure that we're measuring the behavior that lead to that outcome. And I know that sounds like, okay, Amber, well, I get that, that's obvious, but it's not always clear to other people that are using that data. So if we can ensure and provide some insight to these teams that we work with on how to measure effectively the behavior that leads to those outcomes, you're able to actually intervene and create much more change in a greater fashion. Also, for those of you that are interested in exploring teamwork and team training to improve patient safety, whether that is in healthcare specifically or team training in other industries, the book that I've mentioned here is by Dr. Eduardo Salas. He is a organizational psychologist, and there is a particular chapter on here that is fantastic for looking at communication tools. This is something that I used a lot during my dissertation because it allowed me to provide a lot of evidence and just showing why certain measurement tools aren't effective in a language that was really clear and easy to understand. And my last point on this slide deals with the piece of communication that I've kind of been trying to really hopefully push hard, in that when we're talking about behavioral principles, just like when we're talking about data, when we're talking about interventions, it is only helpful if we are able to communicate it to the leaders that need to know that information. So going through a textbook like Aubrey Daniels' Performance Management actually allows us to read the same content in a way that is digestible to any education level. And it helped me provide some direction on how to better communicate the priorities that I'm trying to communicate for my organization. Lastly, and I don't want to underemphasize this enough because I think it is something that is incredibly valuable and I'm learning more and more every day. It is not, you should never assume that this is the case, but rely on data. One of the things that I love about behavior science, and that it has really I think that UNR pushes this, like I'm sure many other graduate schools do. Rely on your data. The rat is always right. If you're not using data to make decision making in your workplace, you're probably doing yourself a disservice. And by probably, I mean you are definitely doing yourself a disservice. Whether the data is financial cost benefit analyses, whether it is data to show whether your interventions are working and whether you should continue investing in those interventions, and whether or not it's an individual performance measure or a group performance measure, we have to rely on our data. And again, the more often I get to interact with executives in and outside of healthcare, I realize that not only is reading data a skill and a repertoire that has to be trained, but also using data to make decisions is a repertoire that has to be trained. And so when we think about how we're delivering our data, continuing to use feedback, immediate, often, and always, and considering your audience when it comes to how you communicate that. So I loved this image that I found online, but one of the skill sets of behavior analysts is we're able to take in all this environmental and contextual data and really analyze it in a way that we can communicate effectively to leaders. And so what you see in this machine is everything kind of being taken in all at once, and then the output being something that's really readable and understandable so that people can, one, appreciate data more, and two, use it to inform the way that they drive change within their own organization. So those are my main points that I wanted to share. Again, high-level overview of what's happening within healthcare, but really just highlighting if you are someone who is interested in healthcare, or if you are someone who is interested in looking at patient safety, what tools and strategies and interventions have been most effective for me, and trying to give you guys some resources so that you can use that information to drive the work that you are doing in your own programs or in your own organizations at this point. So happy to open it up for any questions. Okay, so Josh says, hi Amber, what do you think is the best way to learn about the revenue streams and metrics that are most important for healthcare organizations and their bottom line? For example, Medicaid reimbursement is an important revenue stream for hospitals, their star rating, etc. This is an excellent question. What do you think? So we learn about revenue streams. Okay, so I'm happy to actually take this question with you, Josh, offline, because I'm happy to help provide some insight as to what we're specifically doing at Renown Health. I know what drives me and my metrics in service excellence is dealing with, one, that star rating, but two, also the Press Ganey HCAHPS data. So it really depends on the service line that you're working in. Now, if you're talking more on like Medicaid reimbursement, I have to be honest, I am not the most effective person to answer that, but I'm happy to make sure that we get an answer to you. Does anyone else have any other questions? Hi, Ingvi. And I have one question coming from Nick. I don't know, can everyone else see the questions that are coming up? Okay. Okay, Nick, so Nick is, since everyone can read this, I'm just going to read it myself. That is a fantastic question, Nick. So just to kind of give you a little context, one of the things that my team is working on at Renown is we are working on purchasing and integrating an application that people can round with. So when they're going around and rounding with their patients, they're able to live take data on what's happening and then live stream that data so that anyone with access to that application can see how their unit is doing at any time. And so what we're trying to do is integrate the service piece into the clinical quality current standards and processes. So what I mean by that is, since nurses already feel burnt out, overworked, which is something that is totally understandable because in most cases they really are, trying to, instead of add new processes, alter the way and refine the way we are delivering current processes. So, for example, a lot of it has to do with language. Instead of saying, is your pain assessed? We might change the way that we ask that question. So we might ask them, so that they feel more in control, what are your pain goals? And what can we do to help you meet those pain goals? So really what I'm finding, and nurses seem to be very receptive to that, rather than saying, okay, Amber, thanks again, you're adding another piece to my load. What we're trying to work with them on is how we just refine what they're already doing to meet both needs of clinical and service excellence in an integrated way. I've also found that by working with the nursing teams here, they have a committee, their own committee. So they have like a quiet committee to reduce noise. They have a communication committee to improve communication. And me being involved in their work and in their committees and showing my interest and enthusiasm has really helped gain buy-in from their perspective. And they're very excited to help with any strategies and any ways to measure improvement with the work that they're already doing. So I hope that kind of addresses your question there. But it is definitely something that we are facing in our health system as well. Awesome. Another area, Nick, just to kind of add to that, is working with care teams in the emergency department, because I was just down rounding with our emergency department the other day, and although nurses at every level are like kicking butt, they're working as much as they can, and they're really dedicated to improving the health and well-being of our patients. The emergency department is a whole different animal, where a lot of times they don't have environmental services that are turning over the rooms for them. It's something that they're having to turn over very quickly, and they just feel like they're trying to do 50 million things at the same time. So we are working on different interventions to help really streamline the emergency department process flow to help improve patient experience as well. So I'll definitely keep you posted on those processes. Yep. Yeah, most of these interventions, so Nick's point is that the environment is working against them. And most of the time where behavior analysis is incredibly valuable is we know how to design an environment to occasion promote the behavior that we want. So a lot of times it deals with identifying barriers in the environment that are interfering with that behavioral promotion. All right, thank you guys. I appreciate your time, and I appreciate you spending your afternoon listening to me talk about different stuff that I'm really interested about. I do want to add my email on this chat so that I can follow up with any of you guys who are interested. I'm happy to collaborate and try to continue to inform each other and keeping the direction bidirectional, or keeping the conversation bidirectional, so that we can use behavioral interventions and strategies and really disseminate it throughout healthcare. I have one more quick question. You mentioned that Renown was working on an application for data collection that a number of people on a team could have access to. Any thoughts about setting up family emergency content access to lesser version of that app that would help them track data? Yes, I think they are most likely two separate initiatives. The first one, and you guys can look this up if you're interested, it's one of the platforms we're looking at is called iRounds. That deals with tracking patient experience data, clinical excellence data on a rounding metric application. The second piece, Stephen, which would be incredibly valuable, is having transparency to the family members, and having them give feedback to their hospitalized relative. And what typically happens is we're collecting that information post-discharge. However, they are more than welcome to participate when we have the care team rounding and collecting that data as is. All right, Amber, well, I'll let you head out. Thank you guys again. I appreciate your time.
Okay, great. Thank you so much. And thank you to everyone who joined us. We'll get this posted on our YouTube page in about a week.
Awesome. Thank you.
Thank you.